Welcome to Chapter 11. Here we will be talking about healthcare of the older adult, and this starts in your text on page 182. First, we will look at demographics of aging. The proportion of Americans 65 years of age and older has tripled in the last 100 years. Life expectancy has also risen dramatically in the past 100 years. In 1900, average life expectancy was only 47. That means I would die very soon. That's not okay. So glad that it has progressed and increased to about an average age of 78.2. Although this population will increase in number for all racial and ethnic groups, the rate of growth is projected to be fastest with Hispanic population, which is expected to increase from about 6 million, which was way back in 2004, to an estimated 17.5 million people by 2050. That is a lot of people. Looking at the leading causes of death in older adults, first we want to look at that most deaths in the U.S. occur in people 65 years of age and older, with 48% of these being caused by heart disease and cancer. So know that heart disease is the leading cause of death in not only women but in elderly, and this is due to the loss of elasticity of the heart muscle and also the arteries. Preliminary analysis suggests that chronic lower respiratory disease has also risen to the third leading cause of death, and cerebrovascular disease is now the fourth leading cause of death among the population of adults. Note that many chronic conditions commonly found among older adults can be managed, limited, or even prevented. Older people are more likely to maintain good health and functional independence if encouraged to do so, and if appropriate community-based support services are available. As nurses, we are challenged to promote positive, lifelong health behaviors because the impact of unhealthy behaviors and choices can lead to those chronic diseases. Here are some examples, or more examples, of some of the leading causes of death in that older adult population. And while we're talking about the older adult, let's look at nursing care for that older population. So again, note that gerontology is the scientific study of the aging process. It is a multidisciplinary field that draws from biologic, psychological, and sociological sciences. Geriatrics is the practice, which is medical or nursing, that focuses on the physiology, pathology, diagnosis, and management of the disorders and diseases in older adults. Geriatric nursing is the field of nursing that specializes in that care. Nurses who are certified in geriatrics have specialized knowledge of the acute and chronic changes specific to that older population. In addition to those specialist nurses who work in all areas of adult med-surg, encourage older adult patients. Nurses, you must be knowledgeable and skilled in meeting the complex needs of the diverse patient population. Nurses and the caregivers who work with older patients must understand that aging is synonymous with disease, and that the effects of the aging process alone are not only or even the primary contributes to disability and disease. Aging is a highly individualized, multifaceted process. The goal is to help older people sustain maximum functional level and dignity despite physical, social, and psychological losses. So again, we want to look at that preventative health care. We will continue to talk about this, especially when we talk about that aging population. Encouragement works well. So after looking at encouragement, of course, we want to look at those community-based support services and any referrals that we may need to give. And of course, we want to promote those lifelong healthy behaviors. Also, as the nurse, you must be able to differentiate between normal, irreversible, age-related changes and modifiable risk factors. Doing so helps you as the nurse design appropriate nursing interventions that have a positive impact on the outcomes for the older patients, most importantly for their actual quality of life. Note that the well-being of older people depends on their physical, psychosocial, mental, social, economic, and environmental factors. A total assessment includes an evaluation of all major body systems, social and mental status, and the person's ability to function independently. So first we'll look at the physical aspects of aging, and then we'll go into the actual systems. So intrinsic aging, which is from within the person, refers to those changes caused by normal aging process that are genetically programmed and essentially universal within a species. Cellular and extracellular changes of old age cause functional decline and measurable changes in physical appearance, including changes in shape and body makeup. Cellular aging and tissue deficits also diminish the body's ability to maintain homeostasis and prevent organ systems from functioning at their full efficiency. Now we will look at the cardiovascular changes. Of course, heart disease is your leading cause of death in the older adult. Age-related changes reduce the efficiency of the heart to contribute to decrease the compliance of the heart muscle. These changes include myocardial hypertrophy, which changes left ventricular strength and function, fibrosis and stenosis of the valves, and decreased pacemaker cells. As a result, the heart valves become thicker and stiffer, and the heart muscle and arteries lose their elasticity, as said before, resulting in a reduced stroke volume. So calcium and fat deposits accumulate within the arterial walls, and veins become increasingly stiff and tortuous, increasing arterial resistance, and this in turn increases the workload of the heart. It is difficult to differentiate between age and disease-related changes in the cardiovascular function because of the significant influence of behavioral factors on cardiovascular health. So, under normal circumstances, the cardiovascular system can adapt to the normal age-related changes, and an older person is unaware of any significant decline in cardiovascular performance. However, when challenged, the cardiovascular system of an older adult is less efficient under conditions of stress and exercise, and when in life-sustaining activities are needed. So, a careful assessment of the older adult is necessary because they often present with different symptoms than those seen in younger patients. Before we jump into the respiratory system, I do want you to take a look at Table 11-1 in your text on page 186 that goes over the age-related changes in the body system and health promotion strategies. It breaks down each system briefly, and then it gives you subjective and objective findings. And as you saw in the previous slide with the cardiovascular system, it gives you some numbers there to correlate with your blood pressures, and it tells you about pre-hypertension versus hypertension, what your optimal blood pressures are, and of course some of those health promotion strategies. So that is a good representation of all of the systems and a brief breakdown and how we as nurses can help our patients with those health promotion strategies. So when we look at the respiratory system, this seems to be able to compensate best for the functional changes of aging. In general, Healthy, non-smoking older adults show very little decline in respiratory function. However, there are substantial individual variations. Conditions of stress, such as illness, may increase the demand for oxygen and affect the overall function of other systems. Smoking, of course, is the most significant risk factor for respiratory diseases. So, we do want to tell our patients or educate our patients to quit smoking if they are currently smokers. And there are numerous referral programs available now to help smokers stop smoking there, and they have all sorts of new technology out there to assist with that as well. Now looking at the integumentary system, the function of the skin include protection, temperature regulation, sensation, and excretion. Aging affects skin function and appearance. Epidermal proliferation decreases and the dermis becomes thinner. Elastic fibers are reduced in number and collagen becomes stiffer. Subcutaneous fat diminishes, particularly in the extremities, but gradually increases other areas such as the abdomen for men and the thighs for women, leading to an overall increase in body fat in the older individual. Lifestyle practices are likely to have a large impact on skin changes. Strategies to promote healthy skin function include, of course, not smoking, avoiding sun exposure when applicable, using sun protector if you are going out in the sun of 15 SPF or higher, and using emollient skin cream containing petroleum or mineral oil, avoiding those hot soaks in the bathtub, and maintaining optimal nutrition and hydration. As far as the older adults, they should be encouraged to have any changes in the skin examined because early detection and treatment of the precancerous or cancerous lesions are essential for best outcomes. Looking at the reproductive system, contrary to the common misconception or misperception that the older adult is asexual, older adults report maintaining fairly stable and healthy active sex lives as long as their partner is available. Sexual activity declines with the loss of a partner, primarily for women as a result of widowhood, and for men as a result of poor health, erectile dysfunction, medications, and emotional factors. Ovarian production of estrogen and progesterone declines with menopause. In older men, the testes become less firm but may continue to produce viable sperm up to 90 years of age. So, your 90-year-old grandpa can still produce a baby. Just saying. Now, at about 50 years of age, production of testosterone does begin to diminish. Decreased libido and erectile dysfunction may develop, but are more likely to be associated with factors other than age-related changes. In both older men and women, it may take longer to become sexually aroused, longer to complete intercourse, and longer before sexual arousal can occur again. When looking at the musculoskeletal system, of course, we want these people to be able to maintain their independence and perform their activities of daily living or instrumental activities of daily living, which we talked about in the last few chapters. Note that without exercise, a gradual progressive decrease in bone mass begins before the age of 40. As nurses, we play an important role by encouraging older adults to participate in regular exercise programs. They also have that loss of bone density, muscle strength, and size as age increases, along with that degenerating joint cartilage. So, if you have an elderly patient who is both frail and unsteady on their feet or with their gait, they are at high risk for hip fractures. So you do want to be aware of that and prevent falls as well. Looking at the genitourinary or the GU system, this continues to function adequately in the older adult, although the kidney mass is decreased primarily because of the loss of nephrons. Note that in the US, almost 50% of women 80 years of age or older suffer from urinary incontinence. This condition should not be mistaken as normal consequences of aging. It is costly and often embarrassing, and it should be evaluated. In many cases, it is reversible or can be treated. As far as the gastrointestinal system, digestion of food is less influenced by age-related changes than by the risk of poor nutrition. The ability to recognize sweet, sour, bitter, or salty food also diminishes over time, altering the satisfaction of food. Difficulty swallowing or dysphagia increases with age and is a major health problem in the older population. Normal aging alters some aspects of swallowing function. Practices that promote gastrointestinal health include regular tooth brushing and flossing, receiving regular dental care, eating small yet frequent meals, avoiding heavy activity after eating, eating those high fiber, low fat diets, drinking enough fluids, and avoiding the use of laxatives and antacids. Understanding that there is direct correlation between the loss of smell and taste perception and food intake helps caregivers intervene to maintain the nutritional health of that older adult. Now, looking at the nervous system, you want to note that homeostasis is difficult to maintain with aging, but older people have a tremendous ability to adapt and function adequately, retaining their cognitive and intellectual abilities in the absence of pathological factors or changes. However, normal aging changes in the nervous system can affect all body parts. Slowed reaction time puts the older adult at risk for falls and injuries as well as driving errors. Mental function may be threatened by physical or emotional stress. A sudden onset of confusion may be the first symptom of an infection or change in physical conditions such as pneumonia, urinary tract infections, medication interactions, and also dehydration. When we look at those special senses, of course, we want to go through all five senses. Nearly half of the older men and one-third of older women report difficulty hearing without a hearing aid. Most adults have a decrease in visual acuity beginning at age 50. An uncompensated sensory loss negatively affects the functional ability and quality of life of the older adult. However, assistive devices such as glasses and hearing aids can compensate for sensory losses. As nurses, we can enhance sensory stimulation in the environment with colored pictures, textures, and taste. You also want to note that age-related macular degeneration is the primary cause of vision loss in the older adult. When we look at hearing, auditory changes begin to be noticed by about 40 years of age. Environmental factors such as exposure to noise, medications, and infections, as well as genetics, may contribute to hearing loss as much as age-related changes. Hearing loss may cause older people to respond inappropriately, misunderstand the conversation, and avoid social interactions. The senses of taste and smell are also reduced in that older adult. Of the four basic tastes, sweet tastes are particularly dulled in older people. Blunted taste may contribute to the preference for salty, highly seasoned foods, but herbs, onions, garlic, and lemon can be used as substitutes for salt in order to flavor one's food. Here's a true or false statement in regards to mortality and morbidity and adult falls. And the answer is true, and here's the rationale. And we spoke a little bit about hearing and vision changes. And you just want to note that you do not have to shout at people if they do have difficulty hearing. And actually, if they have difficulty with vision, you just want to understand what kind of vision problems they're having. They may need to just wear glasses, which is their assistive device, or a hearing aid if they're having problems hearing. If they are legally blind, you need to see if they're able to feel or read Braille. And there's different things that we can do as nurses to help our patients that have disabilities, even if they have those assistive devices. And here's another question in regards to age-related changes in the body systems. And here's the answer with the rationale. Now we'll take a look at the mental health problems in the older adult. But before we dive into that, I do want to cover a couple of other things within your text in regards to coping, stress, and the family role. So you want to know that coping patterns and the ability to adapt to stress develop over the course of a lifetime and remain consistent in later in life as well. Common stressors of old age include normal aging changes that impair physical function, activities, and appearance, disabilities from injuries or chronic illness, social and environmental losses related to loss of income and decreased ability to perform previous roles and activities. Older children tend to relocate in response to the changes in their lives, such as retirement or widowed, and a significant deterioration in health or disability. Sometimes older adults or couples move in with their adult children, and some continue care in retirement communities. Some may also go to assisted living facilities. These are an option when the older person's physical or cognitive changes necessitate at least minimal supervision or assistance. Assisted living allows for a degree of independence while providing minimal nursing assistance with the administration of medication, assistance with activities of daily living, or other chronic health care needs. Many types of nursing homes, including nursing facilities or long-term care facilities, offer continuous nursing care. Short-term nursing facility care is often reimbursed by Medicare if the patient is recovering from an acute illness such as stroke, myocardial infarction, or cancer and requires skilled nursing care or therapy for recuperation. Quickly looking at the role of the family, two common myths in American society are that adult children and their aged parents are socially alienated, and the adult child abandons their parents when health and other dependency problems rise. When in reality, the family has been and continues to be an important source of support for the older population. Similarly, older family members provide a great deal of support to younger family members. Note that cognition can be affected by many variables, including sensory impairment, physiological health, environment, sleep, and psychosocial influence. Good health hygiene can improve cognition, and as it can treat depression and anxiety as well. One other thing I do want to talk quickly about before we talk about those mental health changes is drug interactions and adverse effects. Note the term pharmacy or the prescription use or administration of more medications than is clinically indicated. This is common in the older adult population. Any medication is capable of altering nutritional status and nutritional health of an older adult and may have already been compromised by a marginal diet or by chronic disease and its treatment. Combining multiple medications with alcohol, as well as with over the counter herbal medications, further complicates gastrointestinal problems. For an example, St. John's wort, as a common herbal supplement effective for mild depression, decreases the anticoagulant effect of Coumadin and interacts with other medications metabolized by the liver. So we want to educate our patients when we're talking about these drugs and what other things they're taking, because most oftentimes they will not tell you about the over the counter or herbal supplements that they're taking because they don't consider them medications. Also, looking at altered pharmacokinetics, alterations in absorption, metabolism, distribution, and excretion occurs as a result of normal aging and may result in drug and food interactions. Note that non-adherence with medication regimens can also lead to significant morbidity and mortality when it comes to the older adult. So now we can look at those mental health problems in the older adult. Changes in cognitive ability, excessive forgetfulness, and mood swings are not a part of normal aging. Changes in mental status may be related to many factors such as alterations in diet and fluid and electrolyte balance, fever, or low oxygen levels associated with many cardiovascular and pulmonary diseases. Cognitive changes may be reversible when underlying conditions are identified and treated. However, the susceptibility of depression or to depression, delirium, and the incidence of dementia increases with age. Older adults are less likely than younger people to acknowledge or seek treatment for mental health symptoms. So when we look at depression, this is the most common affective or mood disorder of old age. Depression among older adults can follow a major precipitating event or loss and is often related to chronic illness or pain. The risk of suicide is increased in the older adult, with approximately 84% of suicides carried out by white men. Depression does respond appropriately to treatment, but is often not recognized and therefore undertreated. Most antidepressant medications are anticholinergics, cardiac, and orthostatic effects. When we look at delirium, this is also called acute confusional state, and it begins with confusion and progresses to disorientation. It is common and life-threatening as a complication for a hospitalized older adult and the most frequent complication of hospitalization. So note that if the patient does have some type of let's say post-operative delirium, you want to make sure you educate the caregivers and the family members that this is normal and that it can be treated and the patient will return to their regular state of mind, especially after anesthesia has worn off. Delirium can occur secondary to numerous causes, including physical illness, medication or alcohol toxicity, dehydration, fecal impaction, malnutrition, infection, head trauma, lack of environmental cues, and sensory deprivation or overload. Older adults are particularly vulnerable to acute confusion because of their decreased biologic reserve and the large number of medications that they may consume. When looking at dementia, the cognitive, functional, and behavioral changes that characterize dementia eventually destroy a person's ability to function. The symptoms are usually subtle in onset and often progress slowly until they are obvious and devastating. First, we'll take a look at Alzheimer's disease. This is the fifth leading cause of death for older adults. It is progressive, irreversible, degenerative neurologic disease that begins insidiously and is characterized by gradual losses of cognitive function and disturbances in behavior and affect. AD can occur in people as young as 40 years of age, but it is uncommon before the age of 65. Note that AD is not a normal part of aging. So, person getting Alzheimer's is not a normal part of them turning 65 or going into that elderly population. They may repeat the same stories because they forget that they have already told them. Trying to reason with people that have this disorder is using reality orientation only increase their anxiety without increasing their function. Personality changes are also usually evident. Patients may become depressed, suspicious, and even paranoid, hostile, or even combative. A definitive diagnosis for AD can be made only at autopsy. The health history includes a medical history, family history, social and cultural history, as well as a medication history. Depression can closely mimic early stage Alzheimer's disease and coexist in many patients. With AD, the primary goal is to manage the cognitive and behavioral symptoms. Although there is no cure, several medications have been introduced to slow the progression of the disease. Behavioral problems such as agitation and psychosis can be managed by behavioral and psychosocial therapies. As nurses, we can play an important role in the recognition of dementia, particularly in hospitalized older adults, by assessing for signs during the nursing admission assessment. Because dementia of any type is degenerative and progressive, patients display a decline in cognitive function over time. In the early phase of dementia, minimal cueing and guidance may be all that are needed for the patient to function fairly independently for a number of years. A safe home and hospital environment allows the patient to move about as freely as possible. Night lights are helpful, particularly if the patient has increased confusion at night, meaning sundowners. Driving is prohibited and smoking is only allowed with supervision. Note that changes in the brain make it difficult for people with AD to maintain physical independence. Patients should be assisted to remain functionally independent for as long as possible. One way to do this is to simplify daily activities by organizing them into short, achievable steps so that patients experiences a sense of accomplishment. The environment should be kept familiar and noise-free as much as possible. To promote the patient's interpretation of messages, the nurse should remain unhurried and reduce noises and distractions. Use of clear, easy to understand sentences to convey messages is essential because patients frequently forget the meaning of words or have difficulty organizing and expressing their thoughts. Recreation is important, and people with dementia are encouraged to participate in simple activities. AD does not eliminate the need for intimacy. Patients, and their spouses may continue to enjoy sexual activities. Meal times can be a pleasant social occasion or a time of upset and distress and should be kept simple and calm without any confrontations. Many patients with dementia exhibit sleep disturbances, wandering behaviors that may be considered inappropriate. The physical health of a patient is often very stable, and the mental degeneration is gradual. Family members may cling to the hope that the diagnosis is incorrect and that their relative will improve with greater effort. This is not true. Neglect or abuse of a patient can also occur, and this has been documented in home situations as well as in institutions. Looking briefly at vascular dementia, this is associated with cerebrovascular disease in the form of multiple infarcts or strokes in a single larger infarct or small vessel disease. Multi-infarct dementia is the most common form of vascular dementia and has an unpredictable course and is characterized by variable impairment depending on the affected sites of the brain. Therefore, measures to decrease blood pressure and here's a true or false question in regards to Alzheimer's disease. And the answer is false, and the rationale is here. And when we look at nursing care for that older population, older people tend to acquire multiple problems and illnesses as they actually age. A number of problems commonly experienced by older adults are becoming recognized as geriatric syndromes. An additional term known as geriatric triad includes changes in cognitive status, falls, and incontinence. When we look at these, we look at impaired mobility first, and the causes of decreased mobility are varied. Common causes include strokes, Parkinson's disease, diabetic neuropathy, cardiovascular compromise, osteoarthritis, osteoporosis, and sensory deficits. Older people frequently seek help for dizziness, which presents a particular challenge because there are numerous possible causes for this. For many, the problem is complicated by an inability to differentiate between true dizziness and actual vertigo. When we look at falls and falling, the incidence of falls rise greatly with increasing age. It tends to be highest in people who are 85 years of age or older, and outcomes are worse for these adults. Hip fractures, of course, are the most common type of fracture that can occur as a result of a fall. Many older adults who fall and sustain a hip fracture are unable to regain their fracture ability. Causing of falls are multifactorial. Nurses can encourage older adults and their families to make lifestyle and environmental changes to prevent falls. Also, note the myths or stereotypes that some people have these negative perceptions about the elderly, such as that they're not contributing members to the society, or that they're draining the economic resources, or even that they're competing for resources against children. Trust and believe that the older adult population have their own resources at hand, and they don't have to compete with the pediatric population when it comes to having resources and referrals for their health care. When we look at nutrition or nursing management, shall I say, we'll talk about a couple of things. First, we want to, of course, support their cognitive function, promote physical safety, and that goes more into those falls, and promoting that independence of self-care activities and reducing anxiety, agitation, and of course, improving communication. In particular, I want to look at a couple of points. One of which being urinary incontinence. This may be acute, occurring during an illness, or may develop chronically over a period of years. Older patients often do not report this very common problem. Older patients with incontinence should be urged to seek help from appropriate healthcare providers because incontinence can be both emotionally devastating and physically debilitating. When we look at increasing susceptibility to infection, influenza and pneumococcal vaccines lower the risk for hospitalization and death in the older adult. So we need to teach our patients about getting these vaccines. TB affects a significant amount of older adults as well. The CDC guidelines suggest that all patients newly admitted to nursing homes receive a Manitox PPD test unless there is a history of TB or previous positive response. Looking at those atypical responses, older adults who are experiencing myocardial infarction may not have chest pain. Hiatal hernias or upper gastrointestinal distress is often the cause of chest pain. The baseline body temperature for older people is about 1 degree Fahrenheit lower than it is for the younger person. A temperature of 100 degrees Fahrenheit in combination with systemic symptoms may signal an infection. A temperature of 101 almost certainly indicates a serious infection that needs prompt attention. For many older adults, they equate good health with the ability to perform their daily activities and believe that you are as old as you feel. An illness that requires hospitalization or a change in lifestyle is an imminent threat to their well-being. Older people admitted to the hospital are at high risk for disorientation, confusion, change in level of consciousness, and other symptoms of delirium, as well as anxiety and fear. In addition, economic concerns and fear becoming burden to families often lead to high anxiety in the older population. Older people may be unable to respond effectively to an acute illness, or if chronic health condition is present, they may be unable to sustain appropriate responses for a long period of time. Look at nursing management, and we continue this on. Let's look at elder neglect and abuse. Older adults who live in communities and institutions can be at risk for abuse and neglect. Neglect is the most common type of abuse. Other forms of abuse include physical, psychological, emotional, sexual abandonment, and financial exploitation. Nurses should be alert to possible elder abuse and neglect. During the health history, the older adult should be asked about abuse during a private portion of the interview. When we look at social services, other community support services are available to help other older people outside of their homes. So do not think that there are not any resources available. Hospice is a program of supportive and palliative services for the terminally ill patient and their families, and that includes physical, psychological, social, and spiritual care. When we look at aging with a disability, there are still large numbers of gaps in our understanding with the interaction between disability and aging, including how the interaction varies depending on the type of degree of disability and other factors such as their socioeconomics and gender. For adults with disorders such as polio, multiple sclerosis, and cerebral palsy, aging may lead to a greater disability. It has been proposed that nurses view people with disability as capable, responsible individuals who are able to function effectively despite having a disability. Looking at those ethical and legal issues, we'll talk about in just a second. And here again, it talks a little bit about the pharmacological aspects. And this just goes over the differences in that elderly population, the polypharmacy, shall I say, and how taking multiple drugs affects the absorption changes, the metabolism, distribution, and excretion. Of course, your nursing implications, you need to adjust the dose, and this is talking in reference to medications. Start low and go slow is a term the same that we use. Make sure you know the medications, like I said before. Make sure you're assessing these patients in regards to their home remedies and over-the-counter medications because they may be potentially mixing and harmful with their prescription medications. Looking at these geriatric syndromes, we talked about them before and we went over them. The one biggest one that we look at is, of course, our falls and falling and susceptibility to infection. We also talked a little bit about altered systemic responses. And I talked a little bit about each one of these. I do want to make sure you look at the ethical and legal aspects when it comes to the older adult. And as nurses, note that we play an important role in supporting and informing patients and families when making treatment decisions. This nursing role becomes even more important in the care of aging patients who are facing life-altering and possibility of end-of-life decisions. An advance directive is a formal legal endorsed document that provides instructions for care or a living will or names a proxy decision maker, which is known as that durable power of attorney. We spoke a little bit about this in class. If no advance arrangement has been made and the older person appears unable to make decisions, the court may be petitioned for a competency hearing. If the court rules that the older adult is incompetent, the judge appoints a guardian, which is a third-party person who is given powers by the court to assume responsibility for making financial or personal decisions for that person. People with communication difficulties or mild dementia may be viewed as incapable of self-determination. Most people with mild dementia have sufficient cognitive capability to make some, but perhaps not all, decisions. So you just want to be aware of those legal and ethical issues when it comes to dealing with the older population, as well as any of the potential economic effects. And with that stated, we are completed with chapter 11, which is healthcare of the older adult.